And we're recording. All right. I was just wondering if I was getting the silent treatment because I said hello and I didn't see no one spoke back. So I just figured I'd type it. Cool. So let's start off with some questions you guys may have. A lot. Okay. Question number one. That's fine. Okay. So a question that came through is which electrolytes are related to each other? So you know that calcium and phosphorus have a relationship, right? And what is that relationship? They're opposite. Okay. And you also know that potassium and magnesium also have a relationship too, right? Okay. So what someone typed in was opposite, and they said, yes, opposite. So those are they're usually related. But remember from a couple weeks ago when the first lecture, the first thing I said is to remember that you're going to deal with each of them individually. So don't get caught up in trying to link them to each other. So basically take the information, at face value. Does that make sense? Okay. You actually have to raise the mag in order to get the potassium up. That's the K. But calcium and phosphorus are linked together. They're usually seesaw. So if your phosphorus is up, then your calcium levels will be down, and then vice versa. So that's why it's the seesaw. So one go up, one go down. Okay. But that was one lecture. We did cover sodium, we covered potassium, and I believe we started on phosphorus, if I remember correctly. And then there were already Zoom sessions out there. So how many of you looked at the Zoom sessions that were posted previously? Anybody? Okay, so one person said they did. Oh, I'm not sure what Picmonic is, but okay. 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 Which is fine. If you didn't remember about the previous sessions, no big deal. So tell me what you guys have been studying and what seems to be confusing. So I kind of know how to gauge the session. And I gave it a 3-hour window, just, I don't know if we need all that time, but I just want to give it enough time so that way I make sure all of your questions are answered beforehand. Okay, signs and symptoms. Okay, studying everything, remembering the interventions. That's true. Remember, this is that test I said it's almost like rote memory, that you either know it or you don't. And that part's kind of true because with electrolytes, you either know it or you don't. The main thing is understanding what hyponatremia really is, what does it look like, or hypernatremia, hyperphosphatemia, hypophosphatemia, and understanding if you give them medicines to fix one, it could actually push them to the other side. So the things you would monitor for would be things that would affect that process. Does that kind of make sense in saying that? That was one of, when we did the metabolism we looked at Cushing's and aldosterone and Addison's disease. And the one highly missed question was that you all didn't understand once you treat them for Addison's disease, you would be looking for signs and symptoms related to Cushing's. Well, K-sparing can actually cause hyperkalemia, which means potassium. So if someone had a question about K-sparing drugs. If you use a K-sparing drug, K-sparing means the potassium is never touched. So if the potassium is never touched, like spirulactone, then if you give them, or if the patient is taking a lot of potassium rich foods, or they're eating a lot of potassium rich foods, this could potentially cause them to have hyperkalemia with a K. So, does that make sense? Okay, be more specific about nursing interventions and patient teaching. Well, there was a question about mannitol. We're going to get to that in a second, but there was a question that was about nursing diagnoses or nursing interventions and patient teaching. So I want to, address that. So do you need to do the teaching for someone who has like a hyperkalemia or hypercalcemia? Yeah, you do. You need to tell your patients the exact same thing that I'm telling you to watch out for would be the exact same things that you need to be telling them to watch out for. That's all a part of patient teaching. Okay. What's your specific question about mannitol? When do you use it? It's usually used for patients that have cerebral edema. So like a head injury patient, but that's to help pull fluid. It's not for the kidneys, it's actually for the brain. But what's your specific, when to use it? That would be when to use it. So if someone has cerebral edema, head injury, and they have brain swelling, but that's when you would use mannitol, because you're using the osmolarity or the osmolality to actually pull that fluid out and have it drain. But you don't use mannitol for volume overload. You use Lasix to help get rid of volume overload. Not sure of your question about the hypervolemia and hyponatremia. Can you have hyponatremia? Are you asking that in relation to cerebral edema? That was a question for Ashley, I'm sorry. Okay, so if you have hyponatremia, and if you had SIADH, I'm just going to use that as an example, but that can happen whether you have hyponatremia, can happen without syndrome of inappropriate antidiuretic hormone. So that can happen without that. But we're going to go back to the hyponatremia. So that means decreased sodium and hypervolemia. If you have water retention, then it's going to dilute your sodium. So you're going to have hyponatremia, so that hopefully you guys got that, because all the electrolytes would primarily be kind of diluted. But if the sodium level drops too low, then we're going to end up with cerebral edema. And that's usually associated with a high rate of mortality. So you'll start noticing, how do you know a person has cerebral edema? Well, they'll have a change in mental status. That mental status may move on to, now they're having seizures and now they're having a coma, but it's going to continue to progress. So when you're looking at hyponatremia as a whole, if that number is too low, the first sign is going to be something neuro-related. So that would be the thing we would be looking for. So we don't want it to drop too low. And then we don't want to push them up too high. And when I mean push them up too high, we don't want to replace their sodium more than 12 milliequivalents per liter in a 24-hour period. We don't want to do that. Hang on one second. All right, sorry about that. Meant to put that on mute. Okay, so if you replace their sodium back too quick in a 24-hour period, then they're going to end up with neurologic damage. So that neurologic damage will be secondary to them developing demyelination. So we don't want to do that. All right, pardon me. This must be for real. Hold on. Sorry about that. My kiddo's in San Francisco. I just need to make sure that everything was good. All right, so moving on. So someone asked about hyponatremia related to excess fluid. This is what we're talking about in the first place. So anytime where there's excess volume, which would be like water retention, then that would happen with dilutional, you'll have a dilutional sodium. So you guys are asking the same question, but just differently. Does that make sense? So everyone's asking about the dilution in the cerebral edema. If you have hyponatremia and that hyponatremia drops too low, whether you have the fluid volume excess, we're going to start seeing problems. Okay, so someone asked the same question. What about hyponatremia caused from excess fluid? So I've already answered that one. You would use mannitol if you have cerebral edema. So that's two separate questions. Okay, so what does Brunner say about the appropriate IV fluids to use? Because if you're trying to replace sodium, that was and I actually did that lecture. You had that lecture face to face. So what did you write down in that lecture? Because I feel like I'm spending time on a previous lecture and I would rather talk about stuff that I haven't even lectured over. So what does Brunner say for IV fluids to use? Because I actually broke it down. If you had a hypovolemic patient with sodium, with hyponatremia, or if you had a hypervolemic person that had diluted sodium, what would you do? If you had SIADH, how would you treat that in relation to hyponatremia? That was the very first lecture that I gave. Okay, so if you have hyponatremia and hypovolemia, then that person's going to need 3% sodium, but that's in your book. So you would need a solution to give you that bump in sodium very quickly. But you just can't give it really fast because this is really hard on the veins. So you have to give it really slow and you have to watch the patient at that time. That person needs a central line, so we shouldn't be doing that via peripheral IV. Okay. So the way that it works, it is a hypertonic solution. And it works by shrinking the cell, pulling the water out, causing fluid volume overload. So this is where you have a decrease and a decrease. So it's decreased sodium, decreased volume. But if your sodium level is less than 120, that's when they're going to give that 3% sodium chloride. All right, there's a huge request for somebody to mute their phone. So if I personally can't hear it, but make sure all your phones are muted, because whatever's coming through, your classmates are hearing that instead of this, what they're trying to get answered. Okay, so if they have hypervolemia and the sodium is diluted, then we're going to restrict fluids, which somebody already wrote. Some may receive diuretics to excrete the excess water, but to conserve the sodium. If they have renal failure, then they're going to actually go to dialysis. Okay. If they have SIADH, we're going to restrict fluids, but syndrome of inappropriate antidiuretic hormone means we don't have enough antidiuretic hormone. So we now need to give them replacement antidiuretic hormone. Or not, they have too much that they're producing, my bad. So we're going to give them antidiuretic hormone antagonist, not agonist. And then a good example for that would be declamycin or any of the tetracyclines. So we don't give it with food, especially dairy products or antacids, because it binds to the cations and affects the absorption. If you have patients on lithium, then you need to check the lithium levels, because the body will conserve the lithium and not be excreted well when the sodium levels are out of whack. So things that you can give them will be Vaprisol. That's another one that you can give if they have SIADH. You can give them that. Samsca or tolvaptan is an oral medication that can treat hypervolemic and euvolemic hyponatremia. So you have a couple of options of what you can give your patients to help treat at least, your sodium losses. So I'm not sure who the iPhone person is. I think but either way, if they do, if they have hyponatremia and that means decreased sodium, then you need to check the lithium levels, because the lithium levels will be elevated. I think that's the question you're trying to ask. So just kind of a recap, because I think there's too much crossover in relation to the sodium. There's several different conditions for which the sodium could be lost, or where you can have hyponatremia, but you cannot group them all together. And I think that's why you guys are confused. It's the one caution that I gave you in the beginning that you're doing anyway. So I would go back and separate out hyponatremia related to hypovolemia. That's number one. Then I would do hypernatremia in a person that is hypervolemic. That's number two. Then I would go in and look at patients that have syndrome of inappropriate antidiuretic hormone. That would be my third patient. Does that make sense? So I think what you all are trying to do is you're trying to group them all together, but you can't, because each of them are going to be treated differently. And if you go back to the original way, just taking them out separately, I think that will help clear up a lot of the questions that you've been asking. So you have hyponatremia, normal volume. You have hyponatremia, low volume. Then you have hyponatremia, excess volume. And then you have syndrome of inappropriate antidiuretic hormone. So they're all separate, but they all have hyponatremia. So when I did that lecture, I said there was different types of hyponatremia. And I did that so that way you would not try to group them all together, because they each require something different. even if their causes are relatively the same. Okay, so go back and separate them out, back like I did in the lecture that kind of talked about if you had euvolemic or normal volume, but your sodium is low, then what does that do to? So the water in the body increases, but the sodium stays the same. Therefore, no edema. So the sodium becomes diluted because there's too much volume. So a condition where that would happen would be like SIADH, adrenal insufficiency, Addison's disease. Those would be a time where you would have decreased sodium, but the volume's normal. But internally, the volume isn't normal. It's actually excess. But the patient doesn't have like outside swelling. Does that make sense? It's the cells that's being affected. If you have low sodium and low volume, then you probably have vomiting, you may have diarrhea, you could have gastroenteritis, you may have suctioned the person too much, the patient may have had too much diuretic therapy, so they've taken Lasix and peed off a whole bunch of urine, but your sodium goes with it. They could have been burned. So there's a variety of reasons of why you have decreased sodium and decreased volume. Decreased sodium and increased volume. So they're both increases. They cause volume overload. The sodium becomes diluted. Now you start seeing a person have edema, where before when they had normal volume, you probably would not have seen the edema. Because do Addison patients have excess volume? No, they're usually thin folks. But the internal volume, the circulatory volume is completely different. So your decreased sodium that's related to hypervolemia or volume overload would be something like heart failure, kidney failure. You gave somebody too much saline. The patient may have had liver failure. So that would be the reason for that condition. Okay. Regardless of how any of those came about, sodium still has, certain signs and symptoms. So you'd be looking for things like, decreased LOC, monitoring for seizures, abdominal cramping, confusion, lethargy, they're tired. So this is when, all of that's related to salt loss, loss of urine, decreased appetite, orthostatic hypotension, overactive bowel sound. So all of those are signs and symptoms a patient would have if they had hyponatremia. What do? You watch the cardiovascular, respiratory, neural system, the renal system, the GI system. So all the things that we talked about, they can have heart failure, this could be related to GI, they can have liver failure. We're going to be looking at those systems to monitor. And then we start moving into the treatment. So if they have, decreased volume, decreased sodium, we need to, and if it's really low, we need to think about that 3% or that hypertonic solution so they get more salt, less volume. You just can't give it, guns a-blazing. Okay. Foods that are rich in sodium, remember it was bacon, canned goods, and these are things we've already talked about in previous lectures. Hot dogs, lunch meats, all those processed foods, table salt, those are things that you could tell them to do or to add as a part of their diet. Now, if the person had hypernatremia, now when they have too much salt, those are all the things you're going to tell them to what? Do or to avoid?
I said not that you're probably wondering.
That's a question.
Let me go do a blood sugar. Let me go do that real quick before I go to 9
All right, we have two folks that are on the phone that your classmates are asking to mute. All right. Okay, so if you have a person that has hypernatremia, then the bacon, the processed foods, all of that, you have to avoid it. Okay, so we're going to now dovetail into the hypernatremia. That's completely different. So this is when the number is over the 145, right? So if you have that, then we're going to be looking at, it's like an overproduction of salt or too much salt in the body. So a condition would be like Cushing's syndrome, the overproduction of the cortisol, hyperventilation, so breathing, doing the bag valve mask too fast on a patient. Increased sodium intake, so you're eating those processed foods and canned goods, etc., or you're cooking food with salt, then you're salting the food before you even taste it. GI feedings without adequate water supplement, after the feeds. Hypertonic solution. So if you give someone too much 3% sodium chloride, then you can push their sodium levels too high above the 145. That's the reason why we do not want it to increase more than 12 milliequivalents per 24 hours. Okay. Loss of fluids, dehydration, fever, sweating, thirst impairment. So, basically we don't want to give them fried foods because we know fried foods is just doused in salt, Lowry seasoning salt, all that. Garlic salt is just something salt. So how would they present? Fever, flushed skin, restless, agitated, increased fluid retention, edema, extremely confused, but their urine output would be very low and probably concentrated. Dry mouth and skin. So those would be the things that you would see related to hypernatremia. So what are we going to do? This would be the same thing we'd tell our patients. We're going to restrict sodium intake. So all that bacon, butter, cheese, processed foods, deli meats, hot dogs, all those things they need to stay away from. Table salt. Patient safety measures. We will be concerned about their confusion and their agitation. So the fluids that we would give for these folks would be isotonic, which is same as our salt water in our body, or hypotonic IV fluids. So we could give them 0.45% 0.45% normal saline, but we got to give it slowly because when we're hydrating the cell, we don't want to give it too quickly and cause cerebral edema. Okay? So we don't want to shift them too quickly. This is the reason why we're going to take our time. So we can give them either 9% normal saline or we can give them 0.45% normal saline, either one. And then we educate them about the diet, the signs and symptoms of, when they know that their sodium levels are increased, like how about feet swelling? Or when, you take your socks off at the end of the day and the sock hem has an indentation in your leg. That's not normal. So does that make sense? So that should kind of clear up the whole hyponatremia and hypernatremia process, or at least I hope it does. Hang on a second. You differentiate which fluid to give based off the physician's order. So it's going to be the physician's choice whether they're going to use isotonic or hypertonic solution. And are you referring to hypernatremia? Okay, it's going to be the physician's choice, but I can tell you they're going to go with the 0.45%, and the reason being is because 0.9 would provide more sodium, and we already have hypernatremia, so they're going to try to work on more dilutional process at that point to kind of get it down. That's the reason why they'll go with the 0.45%. They're just not going to give it quickly. So yes, it's going to be physician's preference. Just know that they'll probably start with the 0.45 first to be more conservative, and they're going to give it slowly. So you won't see someone getting like, 0.45% normal saline going at 125 cc's per hour. All right. So I do remember covering the kalemias because we talked about the different T wave presentations that can happen when a patient has hyper or hypokalemia. So you should be that should not be confusing at all. So if there's not a question on that one, then I'm gonna slide on over to the next electrolyte imbalance. I think I started talking about calcium. Would that be true? I need somebody to go back to those notes about electrolytes. I remember, and it's a vague memory. So, I know it's been so long. All right, so let's just pick up at hypocalcemia. It's not a problem. So we'll pick up there. I think I remember because I remember talking about Trousseau sign and, the one with the blood pressure cuff, the latent tetany. I remember talking about that. That's the reason why I remember something about it. But I've, slept, burped, and cried and everything else since then. So we're just going to slide on to the next piece. All right, so hypokalemia, this is when the blood level is less than 8.6. So this is going to play a huge role with your bones and your teeth, your health of your muscles and your nerve cells. So remember, they kind of function, the cell function, blood clotting, all of that's going to be a part of that. Oops. So calcium, the calcium absorbed in the GI system. So if you have any problems with malabsorption, like Crohn's, celiac disease, then those individuals are going to have hypocalcemia. Remember, it's stored in the bones, and we can use vitamin D to help uptake the calcium. So that's kind of the role of vitamin D, is to help get more calcium into the bones. Excreted in the kidney, so you have the potential to excrete out too much calcium, so that would definitely cause a problem. Then we have calcium and phosphorus. They affect each other inversely, so they have the seesaw effect. Causes of low causes of low calcium would be due to, what would you think would be the primary concern of a person having low calcium? Okay, low intake, what else? Besides malabsorption. Think about your neckline. Besides renal failure. Besides low vitamin D. Those are all good. Hypoparathyroidism, thanks Midori. So neck surgery, if you have thyroid removed, if someone takes out your thyroid, remember those parathyroid glands, you have 4, 2 on each side of each thyroid. So if they take off the right side of the thyroid gland, then you've lost the right side, both of those parathyroid hormones that exist on the back side of the thyroid gland. So usually they have low parathyroid hormone. It could be from either destruction, removal, any neck surgery, or thyroidectomy for the reason why their calcium levels are low. Outside of low intake, and that would be related to alcoholism. Wound and drainage, that you lose calcium there, especially if you have a wound in the belly, because remember, that's where calcium is absorbed. Celiac and Crohn's disease, acute pancreatitis, low vitamin D intake, which someone already addressed. Another one that was addressed was chronic renal failure disease. So we have excessive excretion of the calcium. So we have waste that's going, it's just basically wasting it. If our phosphorus levels are too high, then our calcium levels are going to be too low, right? Medications. Again, if we take too many magnesium supplements, then it's going to decrease our calcium levels. Laxatives, anything that have like milk of magnesia. So if you take too much of that, then you run the risk of your calcium levels dropping. Loop diuretics and calcium binders. Other things would be just not moving around, so you're not getting what's needed to the bones. So if you're just kind of laying at home, you know, or you're bedridden, then that person's going to have calcium issues. Gastric bypass would definitely put a patient at risk. They lose a lot of minerals and nutrients. So signs and symptoms that will happen is they'll be confused. They'll have hyperactive reflexes. They will have arrhythmias, like their QT will be prolonged. So between the Q wave, from the Q to the T, that area is going to be elongated, as well as the ST segment. They'll have muscle spasms in the calves, in the feet, and they can also have seizures. They're positive for Trousseau's sign, which is it's where you put the blood pressure cuff on in the upper arm and you inflate it and you kind of hold it for 3 minutes, and you're going to actually inflate it over the person's normal, what your last systolic blood pressure was. So say, for instance, you took a blood pressure on a patient, it was 130. So you're going to inflate the cuff to 140 or 150. Okay, and then you're going to hold it there for 3 minutes. And on its own, if you have this positive sign, then because we have negative blood flow distally, and the patients with decreased calcium and neuromuscular irritability will start to have spasms in the arm and the hand. Okay. Chvostek's sign is hyperexcitability to the facial nerve. So that's cranial nerve number 7. And so when you tap the jaw angle in the front of the tragus, so this is your tragus right here, and I remember showing that to you guys. So when you tap there, the masseter muscle on the affected side, then you're going to start getting the lips and the nose are going to twitch to the side that you're tapping. So that's would be your Chvostek sign. So we have one, we pump up the blood pressure cuff, we hold it, and then the arm spasms where basically the hand is also going to flex. And then the Chvostek sign is where we tap right in front of the tragus, which is right in front of the ear. Here's a little piece, little bump. And then right next to the temporal, where the temporal pulse is, that's right in front of the tragus. So that if you tap there, then the nose and the mouth will twitch directly to that side. So doesn't matter where the stoma is in the GI for absorption or calcium. I don't think it matters, to be honest. I think they're going to have deficits especially if they don't have replacement, because they can't absorb it. Usually it's not going to be in the large intestines, and in your small intestines, that's where all your nutrients are absorbed. So that's why it's going to be an issue, because your large intestines, you absorb water. All right, so interventions. We want to look at, they have fall risk precautions we need to be concerned about. Laryngeal spasms we need to be concerned about. That would be significant. We need to consider giving them what kind of replacement to increase their calcium. What should we give them besides vitamin D? Vitamin D helps with the absorption, but if calcium is low, we need to give them some type of calcium supplement. So calcitonin, calcium citrate. Okay. What if they need an IV? So we actually give calcium glutamate versus the other one. So we need to give that slowly, and we're going to monitor their rhythm. So calcium glutamate is their IV of choice, but we do need to make sure that we monitor the IV site for infiltration and phlebitis, because calcium glutamate does cause tissue sloughing. So we probably want to have a central line. Watch patients for DIG toxicity, because if we give them calcium glutamate, for some reason, it also causes the DIG to stay in the system longer. So they can end up having high digoxin levels. We can also give them oral calcium with vitamin D supplements. So we're going to give it after the meal, since it's absorbed in the GI. And we also want to give it at bedtime with a full glass of water. What do you mean by hypermag? Someone brought up about hypermag. So what's your question there? Like with a pregnant patient. Okay, so the magnesium for the pregnant patient is because of magnesium levels being affected related to eclampsia. So if you have mag tox, then you could give calcium glutamate to fix that. Was that your question? Okay. So yeah, let's try to keep the lecture just on this abnormality. So that way, if we keep crisscrossing, because you'll see that calcium glutamate is given in a couple situations, but let's try to understand it kind of linearly and then make the connection. But I don't mind. So just, but if someone reading it, they'll be like, oh, do I give magnesium for the calcium? So I want to make sure we're clear on what we're really treating when we're having hypocalcemia. The other one is calcium chloride. And the reason why we do not give this, so don't pick that as an answer if on any exam, NCLEX, HESI, I'm just explaining the reason why we go with the gluconate and not the chloride. And that's because the chloride produces a significantly higher ionized calcium level than the gluconate does. And it is not used as often because it's a lot more irritating and sloughing to the tissues than gluconate. So that's why gluconate is the better choice. So when you're reading in Brunner and they talk about calcium chloride, the reason why we don't give it is because of the negative effects associated with it. Because the calcium also exerts a similar effect to that of digitalis, then can cause, the dig toxicity level. So we're going to be watching out for, cardiac arrhythmias and patient abnormalities. Let's see. From a nutritional standpoint, we already talked about vitamin D. So we're going to give that to absorb the calcium. We can also look at calcium replacements. We can use aluminum hydroxide, calcium acetate, or calcium carbonate antacids that may also be used to help treat low calcium levels. But they will use those more for phosphorus than for calcium because they will use that in your patients if they don't have renal failure. That's what I wanted to say, chronic renal failure. So how much dietary calcium should you take per day? What's the minimum? Okay, so Betty, before I say that, let me go back to Betty's question. We're giving calcium glutamate, Betty. We're not giving calcium chloride. I was just explaining why we're not giving the calcium chloride. So when you have hypocalcemia and you need to give it IV, you're going to give the calcium gluconate. Whole different situation on calcium chloride. Most people do tend to stay away from it. They'll just stick with calcium glutamate. All right, so you need to give 1,000 to 1,500 milligrams per day. And that's what you should have in an adult. And foods that are rich in calcium are green leafy vegetables, like collard greens, canned salmon, sardines, oysters. Those are all good to replace calcium. Cheese, spinach, rhubarb, tofu, those are some additional foods that can be recommended. If the calcium levels are too low, then they do run the risk of developing seizures. So if your patient does have, remember, phosphorus would be high, usually when your calcium is low. So the doctor may actually order, the aluminum hydroxide and all of that to decrease the phosphorus levels in order to increase the calcium levels. So that's when they would use that. Okay. So if I'm looking at hypocalcemia, then the things I would be looking at are what are my causes? I'd be looking at how would my patient present? I would be looking at interventions that I need to utilize to verify whether this is hypocalcemia. So the Trousseau's and the Chopsteck sign, I'd know what those are, what they do, and then how am I going to treat it? So what are my options? What are things I need to look for? Laryngeal spasms, I need my calcium gluconate, but I also need to make sure I monitor my IV site. I need to consider my DIG people. So anything where toxicity is going to play a role, I need to monitor for that. So you can't ignore that piece, because in practice, those are things you have to do. You can't say, well, I just want to know which medicines to give. Okay, that's fine and dandy, but if you don't know how this is going to impact your patient, then you're already behind the 8 ball. So you can't shortcut it. DIG is very significant. Somebody on lithium, that'll be very significant, and some of the other conditions that we've already talked about. So we're going to talk about treating the problem and how to treat the problem. And then when we'll educate our patients on the same things, you need to make sure you have, non-slippery shoes on, or you don't walk around with socks. So you would still be concerned about fall risk. You would still be concerned about laryngeal spasms. You would still be concerned about, the patient not eating properly. So you want to tell them, eat you some more green leafy vegetables, some more spinach, some more collard greens, some more mustard greens, some more tofu, rhubarb, find out what they like to eat. And some of those things may be in there. Do you like sardines? I'm going to tell you now, I hate the crap out of sardines, but for those who love them, more power to you. So that wouldn't be one of the ones that I would partake in. So hopefully there's something on the list that the patient actually likes. It may get tiring eating the same old thing, but that's better than the other side of the coin. Make sense? Okay. So we're going to slide on to hyper. So now we have too much calcium. So now it's greater than 10. This is going to make your patient feel terrible. They're going to feel like crap. So instead of hypoparathyroidism, now they have hyperparathyroidism. Instead of a decrease in calcium intake, now they have an increase in calcium intake. Now it could be on glucocorticoids. They could have hyperthyroidism. They may have calcium excretion is decreased with certain diuretic meds or certain conditions, and we'll talk about that in just a sec. They could have adrenal insufficiency like Addison's disease, or they could be on lithium. So lithium affects the parathyroid and causes phosphorus to decrease. And when the phosphorus decreases, what happens to the calcium? It increases. Thanks, Karina. So the conditions where calcium excretion is decreased is going to be with thiazide diuretics. So if we're not excreting out the calcium, then that means it is hanging on in the blood, causing what? So if we're not getting rid of the calcium and it's staying in the blood, then what condition do we have? We're talking about, we have hypercalcemia. So I'm just linking that diuretic, and the fact that even if you take a thiazide diuretic, you would think, okay, I'm going to pee, but thiazide diuretics, which is the hydrochlorothiazide, it doesn't take out as much calcium. So if that person's eating those green leafy vegetables, etc., they run the risk of having hypercalcemia. Patients in renal failure, you don't get rid of the calcium in the kidneys. And somebody that has bone cancer, so those calciumia levels are going to be elevated. So here, think of the patient as being like weak. That's usually the signs and symptoms that your patient's going to have, is they're going to be weak. Muscle weakness, profound muscle weakness, not just a little bit of, oh, my legs are just tired. It's like super tired. They're going to be tired. They're going to be lethargic. They're going to have hyper or hypoactive reflexes. So what kind of reflexes would they have with hyperkalemia? They're going to have hypo to absent reflexes. So they're going to be absent-minded. They're going to have belly distension secondary to constipation. They may have kidney stones that may form, because remember when we talked about renal calculi, one of the types of stones was a calcium stone, right? So if we have too much on board, then we run the risk of kidney stone formation or renal calculi. For your ECG changes, or you would see a shortened QT interval. So didn't we have an elongated QT interval before when we had hypokalemia? So when the calcium was low, the QT interval was longer. So now we have high calcium, and now our QT interval is going to be shortened, and our ST segment is going to be prolonged. So that will be our ECG changes, or hypercalcemia. Okay, so trying to see what else I want to tell you about that before we move on to other like to interventions and things of that nature. All right, so when you have too much calcium in the blood, it's going to decrease your neuromuscular excitability. And that's because it suppresses the activity at the at the muscle nerve junction. So the tone's going to be decreased in your smooth and striated muscles. So that's why we have a lot of muscle weakness. When you have calcium levels that are, 12, you might start seeing some symptoms of hypercalcemia. When it hits 16, then that's pretty much severe. If you have a crisis, then this is where the levels are going to rise to 17 or higher. So that person's going to be severely thirsty. They'll have polyuria. They'll have muscle weakness, intractable nausea, belly cramps, severe constipation. They could have diarrhea. There's going to be a lot going on. So that's pretty much significant as when they have hypercalcemia crisis, because they can end up in cardiac arrest. Somebody asked me or asked a question as I'm scrolling through to see if I've answered questions. There was a question that came through earlier about calcitonin, but calcitonin is actually used to lower serum calcium levels. So it's useful for patients that have heart disease or renal failure who can't tolerate, large sodium loads. So that's when you use calcitonin. just to kind of make sure we're not confusing that on the hypo side. So the thiazides, although it excretes the calcium out, it does not excrete enough of it, so some is still lingering on. There was a question about thiazides. So it causes a slight elevation in the serum levels because they kind of potentiate the action of the parathyroid hormone on the kidneys. So therefore, it does not allow the kidneys to excrete out the calcium. So hopefully that answers that particular question. All right, let's see let me get to all of those. Okay, we got that one. Did the thiazides, okay, I think we're up to date. All right, so let's start looking at some interventions and what to do. So we've already talked about the things we're going to assess, correct? Things we're going to be looking for, cardiovascular changes, etc. So we want to keep the patient hydrated. Why are we keeping them hydrated? What's the significance, or why do we care? For the renal stone problems, exactly. We're going to decrease calcium in the diet. We're going to also keep them on fall precautions. We're going to monitor the heart, the GI, the renal status, the neuro status. We're going to talk to them about decreasing calcium-rich foods. Correct, Jessica. We want to flush out the stones or prevent them from forming in the first place. So we're going to talk to them about decreasing foods rich in calcium, decreasing thiazide medicines, decreasing calcium supplements, and vitamin D, all those things that we're going to tell them to do for if they have mild hypercalcemia. We give them calcium reabsorption inhibitors, and that's what calcitonin is. So don't be fooled by the calci part and think, oh, it's calcium. Well, it is, but it's actually a calcium reabsorption inhibitor. So it's designed to inhibit the calcium, not produce it. Does that make sense? So we wouldn't use that in hypocalcemia. So in moderate cases, we would give the calcitonin. Then we have like the biphosphonates, we have prostaglandin synthesis inhibitors. We can give aspirin or NSAIDs to do the same thing. I'm not going to answer that one, Moni, about calcium and potassium in inverse relationship, because there's only a handful of areas where we do have an inverse relationship. And every now and again, you may have some crossover of that, but I don't want you leaving thinking that there's an inverse relationship related to all the electrolytes in that, because that's not true. Would you ever hold back on vitamin D? Okay, if you have somebody with hypercalcemia, then you would hold back on the vitamin D. Severe cases, then dialysis. Well, remember, dialysis does not get rid of calcium in the out of the kidneys. It doesn't do it. All right. So I'm sorry, you would do it for severe cases. My bad. I was thinking about something else. My bad. If you do dialysis, you would do it for folks in severe cases. That was my error. I was thinking about something else. But moving on. Okay, so depending on how your patient presents, there's a question about prioritizing the patient symptoms. You would basically treat them as they come. So you would be looking for the lab value numbers. So if they came in and they had absence of deep tendon reflexes, if they were absent-minded, you should be kind of gearing yourself towards that whole, they had super muscle weakness. So if I had somebody who had muscle weakness, I'll be thinking two things. Did they have myasthenia gravis? That would be one. Or do they have some type of calcium issue? And then I would then look at my labs and then treat based on that process. So again, keep everything in I want to say in a silo. Keep your sodiums in a silo, keep your potassiums in a silo, keep your calciums in a silo. And then where there is, you know, a connection between another electrolyte, then we'll mention it in that particular section. But I think this is why most students get confused and they'll say, oh, fluid and electrolytes is so hard, is because you want to tie it to something. But we're giving you the ties, but you're tying it to everything. So I need you to just kind of pull back from that and just silo your material. And just, it's very straightforward. And what I mean by straightforward is either you know this process or you don't. You know, if I said, hey, how do you treat a patient, you know, that has a sodium level of 113, you know, what IV fluids would you use? What would you say? 3%, exactly. So that's why I'm saying pull back from, use one of my famous words, the buffoonery. You need to kind of pull back from that and just kind of woosah, chill, and just take it, you know, boom, this is sodium, boom, this is, you know, potassium, boom, this is magnesium, boom, this is calcium, and then take it from that aspect. When you start trying to crisscross applesauce the whole thing, then you are going to be all over the place. So that's why I keep saying pull back, because it's very easy to go down that rabbit hole. And I'm trying to not allow you to, I'm not even trying to put a crack in the hole for you to go through. Okay. So, you know, I know it's hard and you all are panicking, like, we got to test. But what I need you to do is I need you to take your time. I cannot say this enough. I need you to take your time. I need you to make sure you read the questions. Yes, I know some of you are stuck in that hole. Just slowly back yourself out and just take your time with it. If you don't, then you're going to be kicking yourself in the derriere at the end of the whole thing. Why? Because you're going to say, I knew this, but I went down this rabbit hole because I panicked, this happened, that happened. This is why I'm trying to get you now to say, stop. Let's just stop it and move forward. But when you move forward with that slow roll instead of trying to go full steam ahead. This is the time not to do the full steam ahead. This is the time to kind of, you know, lay back and just, you know, let this process happen. Otherwise, you're going to be stuck and you're not going to know what to do. All right, so I'm just going to pause before we move on to magnesium and phosphorus just for a second, because I just want to see what you remember previously. Can anybody tell me the medication that's used to decrease potassium levels? Perfect. Thank you. So, okay, I'm gonna go with Kristen since you put it out there first. So Kristen, what would be nursing responsibilities related to the administration of Kayexalate? And if you're not sure, then the two subsequent ones, not conditions. I want to know what your responsibility before you give that medicine. And this is kind of part of your portfolio. What would you be checking for first and why? Not cardiac. Where's this medicine going? Not renal. Thank you, Karina. It's going in the GI. So yes, we want to check for obstruction. We want to make sure they have what? Bowel sounds. See, just simple stuff. It is going to cause diarrhea, but it's also it's designed to pull out the potassium, correct? Okay. So I asked about nursing responsibility. Your nursing responsibility would be to make sure the patient doesn't have a bowel obstruction, which means if they don't have any bowel sounds, we can't give this medicine because they probably have something like a paralytic ileus, which now if we give this, we could potentially, not potentially, we will cause more harm to the patient. So we have to check bowel sounds to make sure that they're present before we give this K-exolate to a person that has hyperkalemia. So does that make sense how you back those things up before before you give something, you do your nursing due diligence, which is, the nursing process. We assess before we intervene. Okay. I'm just asking one question. The loop diuretic and all of that, we can give that as well. But if there was my question wasn't just about, it was just about one piece. I just wanted to see if you knew that you were giving K-exolate, what do you do? If you knew you were going to give Lasix, what do you do? Or loop diuretic, you would still have to check blood pressure and you would still have to check potassium levels. There's still due diligence that you would have to do. I was just basically kind of throwing that out there because a lot of times we don't look at, cover, delve into, whichever way you want to put it, into the pharmacology and the responsibility component. Although we do kind of ask it when you do the portfolio, what would be some things that you would be responsible for doing or assessing prior to? And so most of you write that stuff down, but it's like you write it and it just as fast as you wrote it, it went straight out your mind. It didn't stay in here anywhere. It just said, it went on vacation. So that's the reason why I'm just trying to, get you all to see, the information, but for some reason you get stuck and then you just start, it's like that fish out the water. You start gully flopping in that water and then you want to kick yourself because it's something you actually knew and you kind of talked yourself right out of it. So that's why I'm like, stick to what you know. We talked about a couple of situations, where we would have absences of reflexes. So I know Ms. Pritchett covered the magnesium. So if you're treating somebody that has preeclampsia and you're going to give them IV mag, then if you have hypermagnesemia, what happens? What would you see for a sign or symptom related to hypermagnesemia? Exactly. You start having deep tendon reflexes that are absent. So that's the reason why I'm just stick to the simple basics. Don't go all out there and la la land. Okay? You guys really do know this information, but for some reason you talk yourself out of the data that you already know. And then you're like, but I knew it though. And I know you knew it, but it doesn't matter at this point. So let's not try to fall into that spot. So let's move on to something a little bit more positive and then keep going. So does anyone remember the sodium level that I told you is way too low for a person that has hyponatremia, or for a person that has SIADH? 120. So if it's less than 120, then we got a problem. You should be thinking seizures, if not cerebral edema is getting ready to come around the corner, and then how are we going to treat it? What's our treatment for low sodium? Especially that low. Because them little the IV fluid, I'm not sure. We're gonna need to give that hyper or hypotonic solution. Which one? We definitely need to give 3% normal saline. Okay. So it's 3% it's 3% saline. It is hyper. Just checking. All right, I see the per. I want to make sure I wasn't reading that wrong. Okay. Let's talk a little bit about, so do you see what I'm saying about just keeping questions simple? Make sure you read the entire question. Don't stop short on the question. Meaning, I already know what it's going to ask me, and then you hurriedly answer, and that's not really the question that was being asked. And then you're like, oh man, I just stopped right here. I didn't read it all the way through. So make sure you read it all the way through. Okay. What is the medication that you give to treat SIADH? And what is the expected outcome that you expect to receive by administering that medication? Not a diuretic. Declamycin, exactly. Okay, so you're giving a patient declamycin. I want you to tell me, how do you know? How do you know that this medicine is working? Correct, Tiris. You would expect to see the urine increase. Okay? So just don't know what the medicine is for. Also know what you expect it to do. I'm giving this medicine to do yada, 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 yada. Does that make sense? So I'm giving it, I'm expecting these things to go down. So if I was going to give Lasix, and we're just talking about Lasix in general, you would expect someone to have an increase in urinary output, right? Or if I gave somebody a beta blocker, then I would expect their blood pressure to go down. So just know what your expected outcome is, because what if the patient's urinary output didn't go anywhere? Would that be concerning? Absolutely. So this is why you make sure you know the intended outcome of that medicine when you're giving it to a person. You just don't give something free willy-nilly and don't pay attention to it. Okay. What if your patient was dehydrated and urinary output was less than 30 milliliters per hour? So what would you do? What are some things you could do, whether it's a teaching aspect, whether it's a nursing aspect? What would you expect to do for a patient in that predicament? Okay, increase PO fluids, I like. Push fluids. How would you push fluids? How would you do IV replacement? What would you need first? In order to push fluids or push IV fluids and do IV fluid replacement, what would you need first in order to push IV fluids? Not the doctor. He's going to give the order, but I want to know you need IV access. Exactly. So you want to make sure, you have a site to push it. Then what if it was a saline lock? What would you do? So what if they already had just a saline lock or a HEP lock? Would you use it? Okay, check patency, check it first. Okay, it's good. I'm gonna tell you it's good. Now what? Okay, flush it. Okay, that goes in, no problem. Okay, we're good. We're good on the flush. Now what? Okay, you flushed it. So, all right, we start giving the fluids. We start converting it to a continuous IV. We move on from the HEP lock status. Yes, you're gonna need a pump. You can't freehand it. They only freehand pre-hospital. The drip is either slow or fast. There's no in between. It's not sort of kind of fast or sort of kind of slow. So that's not us though. We're not pre-hospital, so we can't do anything like that. We have to have more accuracy to what we're doing. All right, so say your patient starts to pee. What else? What do you want to do once they start peeing? We want to measure it, check color. I like that. Measure, INO, strict INO. Okay, so what else besides measuring it and check color? Clarity, I like. What else? One more. Run a sample to the lab. Okay, so before you send it to the lab, what are you going to do? So you're going to get it. You're going to check for, there you go, Michael. You're going to check for odor. So does that make sense? Don't forget your basics. Don't forget your basics. Why are we checking for odor? Yeah, it is gross. But if it stinks, then you know, oh, we really got a problem. Sometimes you may not necessarily have sedimentation in the urine. So you need to check it to see, hey, is this a urinary tract infection? Is it cystitis? I mean, what kind of infection? Maybe it's glucose. We don't know, but this is why we check it. I hate to tell you, this is the job you're signing up for. That's not the PCT's job. You probably say, why can't the PCT do it? You gonna trust the PCT? Okay. So all of those are just, things you want to continue to look for, the consistency and, what's going on with it. You just want to make sure you do your due diligence. Basically what I'm saying is do your due diligence. All of this, when I keep saying, okay, and I know you're like, oh, is there more? It's not that you're not giving me the right answers, because those are all right, but there is more. And I don't want you stopping short, because once you start that, it's hard to pick that back up and keep going, because now you're already behind the 8 ball. So you have to be mindful, be mindful of that part. Makes sense? Yes, we do our own assessment. Someone goes, don't spill it. I love it. Yes, you got to do it. I mean, all of it, Michael. You just have to, I'm just speaking in general of if you have a patient and you got to do some urine. It's just a basic nursing process. Okay, I'm collecting this urine. Okay, I'm looking at it. I'm measuring it. Okay, I see something floating around in here. I see some sediment. Not sure what it is, but it's some little white flakes, whatever. You know what? This urine stinks. I don't know what the heck is going on. What if the patient had a fistula? See, this is why I'm like, you just can't, you don't know. Can you see a fistula internally? Poop in the urine. This is the reason why I'm saying you have to do your due diligence. So just, I'm kind of being light about it. So, because I know you're all so like, whoop, but it's just, you guys actually know it. You know it, but you're so wound up, and you just need to unwind. Because I think if I plucked one hair off of your head, you'd probably pop. Asparagus. That is funny, because if you eat asparagus, you can smell it in your urine, although it's great for your kidneys. So, certain meds can turn it colors. All of those are the reasons why you're checking, you're smelling, you're looking. You're just not just, okay, this is some peeing you're going on. All right, so let's go ahead and pick back up with hypo. We're going to start with the magnesiums, okay? Usually, if your magnesium level is elevated, your BP is probably going to be low. And if your magnesium levels are high, if your magnesium levels are low, then your BP is going to be high. So just, keep in mind, your normal levels. Do we have a long or a large therapeutic window for magnesium, or is it pretty short? It is super short. I would agree with that. Okay, so this basically tells us we really can't be monkeying around. So 1.6 to 2.6, perfect. Okay, so basically what our magnesium does, it plays a role in cell function, like transferring and storing energy, regulates the parathyroid hormones. We kind of knew that, so it plays a role with calcium levels. It also, if something I was going to say. The release of magnesium is inhibited when your magnesium levels are extremely low. And this is why you see a decrease in calcium levels. It also metabolizes carbs, liquids, and proteins. And then I've already talked about the BP regulation. Okay, so there's a question about the actual levels of magnesium. I'm going to tell you that your Brenner book actually says 1.3 to 2.3. So if we're going to test you on anything, then that would be what we would use for our numbers. If you go to a hospital, there'll be variant, and they're relatively close. So I'm speaking about I'm speaking about magnesium levels in general. Did I check Brenner? I did check Brenner before this meeting. So I see the PowerPoint says 1.5 to 2.5. And as a matter of fact, I made a notation of the page just in case somebody asked me. So if you go to Brenner page 262, and it'll talk about magnesium imbalances, and it says the levels are 1.3 to 2.3. So the magnesium is a very important neuromuscular, it has a very important neuromuscular function. So it's going to act on the muscle neural junction in the body. So if you have variations in the magnesium levels, it's going to affect neuromuscular irritability and contractility. So if you have too much magnesium, then it's going to decrease excitability of the muscle cells. Whereas if you have too little magnesium, then it's going to increase your neuromuscular irritability and contractility. It does have its own sedative effects as well. So it probably by inhibiting the release of acetylcholine. So based on that information, then magnesium is going to somehow follow along with the nerves because of being involved with the neuromuscular junction. So if it's high, then you're going to have some certain neuromuscular issues. If it's low, then you're going to have certain neuromuscular issues, is what it's basically saying. All right, so it is absorbed in the small intestines and it's excreted in the kidneys. So if you have any issues with the GI absorption, then that's going to affect how much magnesium you intake, which can limit your magnesium. So it's, again, excreted by the kidneys. All right, so let's start with low magnesium. So here you have limited intake. That person's probably starving themselves to death. Other issues from electrolytes can cause your magnesium to drop, and that would be the calcium. So that's a relationship I believe Moni was getting at earlier. But is that an inverse or direct relationship? That's going to be a direct relationship. So if mag is low, calcium is low. Also, if you have hypokalemia, if you have a decrease in potassium, then you will also, that's another cause of decreased magnesium. And I talked about that earlier, that there is a relationship with magnesium and potassium, and that you had to increase the magnesium first in order to get the potassium to rise. Wasting magnesium in the kidneys. So usually if a person's on a loop or thiazide diuretic, then they're going to waste out magnesium in the urine. Medications like cyclosporin stimulates the kidneys to actually waste urine. If you have Crohn's disease, celiacs, any type of vomiting, then magnesium will not be absorbed in the stomach. Patients that are taking proton pump inhibitors, like Prilosec, Protonix, and Nexium, that's also causes malabsorption of the magnesium. From a person who's drinking, someone put on their alcoholism, they have poor food intake, so this is going to stimulate the kidneys to waste magnesium. And also, folks that have alcoholism usually develops pancreatitis, so that can also cause them to have low magnesium. A patient that has diabetic ketoacidosis or is on insulin for regulation of their diabetes, then that person runs the risk of developing hypomagnesemia. So since we have neuromuscular excitability, or we have neuromuscular issues, then what we're going to see in this patient is going to be Trousseau's sign, is that will be positive because of the lack of calcium. So Trousseau's is where you put on the blood pressure cuff slightly above the patient's systolic BP, hold it for 3 minutes, and what should you expect to happen? You should start seeing the hand twitch and the hand should contract. Perfect. All right, so their respirations will be weak. They'll have irritability. And then we talked a little bit about torsades de poids. Remember that? When we talked about the differences between the ECGs. So they will have tetany, but the torsades looks kind of like V-tach. But it goes along with a person that has alcoholism. So it's an abnormality of the heart or the heart rhythm, and it's actually a lethal rhythm. Yes, it is accordion-like. Other signs related to hypomagnesemia would be tall T waves, not peaked, just tall. ST segments depressed. They can have the Chvestek sign, hypertension, and earlier that was why I opened up with, if your magnesium is low, your BP will be high. And they'll have hyperreflexia, involuntary movements, decreased bowel sounds, decreased GI motility of the bowels, or decreased peristalsis. So those are all things that you would see with a person that has hypomagnesemia. A lot of times from the all right, so I got old brain working right now. Give me about 2 seconds to go back to what I was thinking before my mind shifted onto something else. We'll just move on from that. You all can laugh at me about that one because actually that's pretty hella funny. All right, moving on. Okay, so let's see. So we've already got all of our ECG stuff. We have our blood pressure stuff. We have our positive signs. Things we're going to look at is we're going to monitor the cardiac, GI, and respiratory systems and the neuro changes. We can look at the ECG. The physician may order potassium, oral supplements, and because remember, if they have hypomagnesemia, they probably have hypokalemia. But we got to give the mag first. So, but it's hard to regulate those. If we're trying to get the potassium up first, if we're trying to get up the potassium, we have to give the mag first. If we're trying to get the mag up, then we have to get the potassium first. So it's you do the reverse. Oral calcium supplements with vitamin D or calcium gluconate. We can give mag sulfate. What's our nursing priorities with mag sulfate? We got to give it slow. Monitor the levels. So how do you know, assess for DTRs, okay? So if we start seeing an increase in, or we start seeing absence of the deep tendon reflexes, what is that really telling us? That we have now too much MAG on board. Okay, perfect. What about seizure activity? Do we want to place them on seizure precautions? Yes. We're going to encourage them to take oral MAG. So this can cause diarrhea. So we want to watch for this because, you know, we don't want them, that will decrease the MAG further. What foods do we know are rich in magnesium? Some chocolate, avocado, green leafy vegetables like your kale and your spinach, your legumes, your oranges, your oatmeals. Yep, all good. How about peanut butter and pork? Okay, peanut butter, pork, cauliflower. Someone said potatoes. What kind of fish would be good? That would be your legumes. So we can give tuna, canned tuna. We can do mackerel, milk and nuts. So all of those would be foods that are rich in magnesium. So yep, mackerel, you got that one. So those would be the things that you would talk to your patients about what to do and then what to look for. So this is how you know that, you know, you've hit the other side of the spectrum. You know, your whole grains, your coca, and that's what they mean by the chocolate. It's the dark chocolate that has more of the magnesium in it. And I don't know if you've ever had dark chocolate, but it is super rich and it's an acquired taste. It's not like the regular milk chocolate that you get in like these little Snicker bars. It's completely different. So yeah, someone says bitter, someone says delicious. As I said, it's an acquired taste. So if you're not a dark chocolate lover, then I probably wouldn't be, you know, flying to the store to go get that. But that's basically how you would do your interventions. Patients that are on digitalis, we're going to monitor them closely because a deficit of magnesium can predispose them to dig toxicity. If it's severe, then we need to think about seizure activity. So, you know, we're going to monitor for that. Other safety precautions, if they become confused, then we're going to be worried about their ability to manage their secretions and their ability to eat food, their ability to swallow. So, you know, difficulty swallowing may happen in a person that has hypomagnesemia. So we just don't want to just be feeding them. We want to make sure that they can swallow and kind of do a little, you know, sippy test to make sure all's good. So if we know the things that can cause hypomagnesemia, then we're going to be looking at the opposite. So if we have hyper, then this can happen if they're trying to correct hypo, and especially if they're trying to correct hypomagnesemia with mag sulfate. Okay, so this is actually less common to have hypermagnesemia than it is to have hypomagnesemia. So it's not like it's a prominent occurrence. So causes would be taking a bunch of magnesium-containing antacids and laxatives like Maalox and Mylanta. So if you're like walking around with a big old bottle worth, just chugging it, not really measuring it, then you may end up with an increase in magnesium because it's not going to be excreted properly. It's going to end up being retained. Patients with Addison's disease or adrenal insufficiency also run the risk of having hypermagnesemia. Your glomerular filtration is insufficient. So, renal failure, you get less than 30 milliliters per minute of filtration. So the kidneys keep too much of the magnesium in. So now this person's going to be tired. They're going to be more lethargic and have profound lethargy. They're going to be really weak. ECG, PR, and QT intervals are prolonged. We have wide QRS complexes, and I'd be worried about them going into VTAC or torsades or something. Patients that have untreated DKA, so that can also cause hypermagnesemia. Deep tendon reflexes are decreased or absent. They have a low BP, bradycardia, respiratory arrest, nausea, vomiting, weak skeletal muscles and that means that their breathing will be impaired, and that's because their skeletal muscles are weak. Patient can literally just go into cardiac arrest. So medications that decrease GI motility, including opioids and anticholinergics, can also increase serum magnesium levels. Yes, hyper is caused from overcorrection of hypomagnesemia when you're trying to correct it with mag sulfate. So yeah, you will actually see that happen. And that can happen if you're doing it from a person that's pregnant and having preeclampsia or eclampsia for that matter. Because remember, for those individuals, what happened? Get a little light in here. There we go. All right, got a little dark. So things we want to do is monitor respiratory, neuro, GI, put them on a cardiac monitor. Remember patient safety because of they're lethargic. So what you need, Ash? Okay. Yes, it is. But remember, that's for your preeclampsia person or your eclamptic person. They'll use mag sulfate. And we do need to check the DTRs. That is correct. Avoid giving magnesium in renal failure patients because, like the mag-containing antacids, we don't want to give them that. We don't want to give them the mag-containing laxatives because they can't clear it. Check for magnesium during the mag sulfate administration and then avoid foods rich in magnesium. Diuretics, because diuretics waste magnesium, so you could give a loop diuretic or a thiazide, so that's good on that one. That was Melania. Seriously, you guys are cracking me up. There is renal failure, so you're going to prep them for dialysis. Yeah. IV calcium. So order to reverse side effects of MAG, so monitor for infiltration, they'll need a central line. So those are all different treatments for a person that has hypermagnesemia. Now, there really aren't case studies unless not from Whittingham. By the time we get to the respective electrolyte imbalance, you just get lost in it. So this is why I'm kind of asking questions here and there and in between, so that way you can, put those pieces together. But the key when you're dealing with someone with hypermagnesemia is looking at those deep tendon reflexes. So that's going to, be your key process there. But, the the most common cause of hypermagnesemia is renal failure. And it's aggravated when your patients receive, magnesium to control seizures. So if we, crank up, if they have high levels then of magnesium, it's going to depress the central nervous system as well as the peripheral neuromuscular junction. So we need to monitor vital signs, pay attention to respirations and if they're shallow, hypotension, and look at the deep tendon reflexes, changes in LOC. So those are things that we need to make sure that we're following through on. Okay. So we've covered all of our respective electrolytes. I think the only thing, I think I didn't cover phosphorus. Correct. That's the only two we have left, and DI. So no, it's not. Someone asked, is chloride on the test? No. Someone goes, what? Too funny. Too funny. Oh, moving on. All right, so let's do phosphorus, and we know that it has, someone goes, check the list. Guys, be nice. Okay, so we know that phosphorus and calcium are tied together, right? Okay, someone says the list lies. That is true. Sometimes that list isn't right. So let's look at low phosphorus. So this is where the phosphorus levels are low, and it can affect your bones, like the calcium in the teeth and the bones. Several metabolic functions, like use of vitamin B, acid base, homeostasis, bone formation. These are all the things that phosphate levels may affect. Nerve and muscle activity, cell division, transmission of hereditary traits, etc. So calcium levels inversely regulate renal tubular reabsorption of phosphate. So basically it's just saying calcium and phosphates are upside down or inversely proportionate. So when your phosphorus levels are up, your calcium levels are down, and vice versa. So we do have an intracellular shifting that takes place. So there's an increased urinary excretion, which is usually the more common. Decreased intestinal absorption, decrease in dietary intake can also upset your phosphorus balance. Patients that drink, it decreases the body's ability to absorb the phosphorus. So, they're already malnourished, so this just makes that condition worse. Then signs and symptoms of a person having hypophosphatemia would be syndrome of refeeding. This is usually seen in patients that are on TPN, so that parenteral nutrition, malnutrition or starvation. So the body goes into survival mode. And so then the food, once that food is starting to be reintroduced, then the body goes into shock. The insulin is released because there's a lot of glucose. And then to synthesize it, the body releases phosphorus, magnesium, potassium, which are already depleted, therefore furthering depleting the phosphorus level. So if you saw that about the syndrome of refeeding, that's what that was really all about. Okay, so some causes that we have is chronic use of antacids containing aluminum hydroxide or magnesium-based antacids because it alters how the GI system absorbs the phosphorus. We also have diabetic acidosis or ketoacidosis, hyperparathyroidism with resultant hypercalcemia. So this is due to increased secretion of the parathyroid hormone, too much secretion. It totally inhibits the reabsorption, so that now we have it being wasted in the urine. Use of parenteral nutrition solution with inadequate phosphate content, vitamin D deficiency, loop diuretics, so your Diamox, your biphosphonates, those will all be a part of that. Patients in acute respiratory alkalosis can also have hypophosphatemia. And so the phosphorus will move out of the blood into the cell. Oncogenic osteomalacia, so that's like, wasting of the kidneys or waste of phosphorus, therefore the phosphorus levels are low, the bones are softened, and this can be related to a tumor or a malignancy. If you get burned, it's going to shift phosphorus out of the blood and into the cells, increase calcium, decrease mag, and decrease the potassium. That's what happens with thermal burns. So those are all causes of hyperphosphatemia. Other drugs that you may be aware of would be insulin, laxatives. Those were all some additional ones that I hadn't mentioned, but I think there was a couple folks on here who already brought that up. So complications of hypophosphatemia would be anemia, heart failure, shock, seizures, coma, just to name a few. So when you have hypophosphatemia, pretty much everything's just broken down. So what I mean by broken down, I mean like run down. So you have breathing problems because you have a lot of muscle weakness. You can end up with rhabdomyolysis, which the secondary to electrolyte disorder. So you end up with necrosis of the muscles that becomes toxic to the kidneys. So now that person presents with tea-colored urine, muscle weakness, pain, decreased reflexes are all signs and symptoms of rhabdomyolysis. In addition to decreased FOS and K, the rapid necrosis releases myoglobin in the urine, or myoglobin in the blood. But usually rhabdo happens if you have some type of muscle injury of some sort. Other signs and symptoms would be, fractures, chest pain, tremors and weakness in their voice, confusion, irritable, bleeding, bruising. All of those would be some clinical findings. So serum phosphorus would be less than what? What are your normal levels for phosphorus? Let's see what we got. 2.5 to 4.5. So anything less than 2.5 is going to be an issue. So if you do a 24-hour urine phosphate, and it's more than 15% higher than the normal, then this indicates that the kidneys are wasting a lot of your phosphorus. Okay. So what's our general treatment? Basically, we're going to treat the underlying cause. We're going to discontinue any medications that can cause the phosphorus levels to go down. We're also going to consider venous thromboembolism prophylaxis. Why are we even considering that? Why do we even care? Okay, because it causes platelet dysfunction. How does it affect the platelets? What does it do to the platelets? Okay. Oops. All right, decreases the platelets. So if you have decreased platelets, does that increase clots? Or if you have increased platelets, does that increase clots? So if you have increased platelets, then it increases clots. Anyone else going to chime in on that, or is it just going to be a couple people? Okay, so we got increased platelets equals increased clots. Okay. All right. If the person has hypophosphatemia, what type of diet would you recommend? And give me an example of the types of foods you would recommend. Okay. So we have quite a bit. Let me back up a little bit. So we would tell them to eat foods that are high in phosphates. Fish was definitely on the list. Organ meats. Would you tell organ meats where you have a person that has when would you tell someone not to eat organ meats? If they have high cholesterol. Okay. So fish, organ meats, pork, beef, chicken, whole grains. Those would be that'll be a good place to start for foods. Milk products, nuts, those are all be some additional ones to add to an individual's diet that has low phosphatemia. We want to give them IV phosphate salts, especially if they have severe hypophosphatemia, and we would give that with vitamin D to increase the absorption of the phosphorus. And the type of vitamin D we would give would be calciferon or calcitriol. Those would be the two that we would use. If the person has hyperparathyroidism that's causing the hypophosphatemia, then we would give them something called Sensipar. So that would be another medicine that could be given to that individual. Other supplements would be like Nutrifos, K-Phos, Fleet's Phosphosoda. So those are all different ones that you may see. The one I can tell you you'll see the most in clinical practice would be capital K and then dash PHOS for K-Phos. So that's usually, it's like a little effervescent type of tablet. Sometimes it may be liquid. It depends on the respective hospital facility that will determine which one you'll end up getting. All right. Other things, what about patient safety? Do we care about that for this particular one? Yeah, we're on hypo, so we're not going to talk about the hyper yet. Can you spell the med with a parathyroid issue? Sure. So it is S as in Sam, E as in Edward, N as in Nancy, S as in Sam again, I as in Igloo, P as in Paul. There you go. Thank you, Kristen. So we want to look at patient safety for, the bed down, call light in place, looking at the TPN, watching for patients that are on TPN, not necessarily looking at it, but for those that are on TPN, we want to make sure that we monitor them for rhabdomyolysis. So we want to make sure we do that. Monitor mental status changes. What if the phosphorus level is less than 1 milligram per deciliter? Then what are we going to check? We're going to speak about more labs at this point. Yeah. Okay. I'll keep going. Those are good. Keep going. So remember that if you're talking about renal failure, somebody put renal failure. How do you know you have renal failure? What lab values? Creatinine and what else? BUN and creatinine. So we're going to look at renal status. We're going to look at the BUN creatinine. If it's high, then remember the phosphorus isn't going to clear the kidneys. So we want to make sure we're looking at the BUN and creatinine. We are going to monitor. There was calcium that was up there. We're going to make sure it doesn't go down. If we have increased phosphorus, we want to make sure that we don't put them on the other side by giving them all this phosphorus. We don't want to now make them have hyperphosphatemia because we're treating hypophosphatemia. Okay. So we talked about the safety measures, seizure precautions. If we're given anything IV, we're going to administer it slowly so that we don't cause hypocalcemia, tetany, or hypotension. Help them ambulate and move around. So do some gentle range of motion. They need a better diet plan. Monitor respiratory status, nutritional intake, INOs. Look for signs and symptoms of decreased or increased calcium. Look for signs of hyperphos or remaining hypophos. So those are things that we're going to continue to monitor for. Okay. Switching gears to hyperphosphatemia. Then we're going to slide on to some of the causes would just be the opposite, right? When you have hyperphos, so anything greater than 4.5 would be hyperphosphatemia. So calcium and phosphorus, they're going to influence each other, as we already know. We're going to look at the vitamin D because that plays a role in how much phosphorus is absorbed. We're going to pay attention to the kidneys because if they're not working, then we would expect our phosphorus levels to be elevated, right? So, yep, kidney failures. What other things we're going to look at? We already talked about how phosphorus works. Regulates the kidneys and the parathyroid, regulates the phosphorus. So if we have a problem there, we're going to have a problem with phosphorus, right? Things that cause hyperphosphatemia, electrolyte imbalances, acid-base imbalances, burns, crush injuries, prolonged immobilization, severe infections, too much vitamin D use, hypoparathyroidism. So if the parathyroid is low, we're going to have high phos, decreased secretion of the parathyroid hormone. The kidneys keep too much of it, overuse of laxatives that contain phosphorus, kidney failure, rhabdomyolysis. What if patients that are getting chemo The good cells die and release intracellular contents into the blood that contains phosphorus, so that's another reason why. The refeeding was back on the hypo. So we got kidney disease, malignancies like leukemia, heat-related injuries, rapid necrosis of the muscles, which is the rhabdo. We got that. Yep. Complications of hyper would be soft tissue calcifications, hypocalcemia, bone fractures, aortic and mitral valve stenosis, especially in patients with kidney disease. So anorexia, confusion, muscle cramping, spasms, tetany, seizures. So muscle cramping, spasms, tetany, and seizures. Shortness of breath, sleep disturbances, hyperactive reflexes. These are all signs and symptoms that you'll see. Presence of Chavostex and Trousseau signs, either or. You can have facial muscle, abdominal spasming, tetany, anorexia. So I've already covered all of those previously. We're going to look at BUN and creatinine because they will more than likely be up or down. They're going to be up. Yep, causes of hyperphosphatemia can also be rhabdomyolysis. The kidneys shut down, develop renal failure, therefore they can't excrete the potassium. Can't excrete the phosphorus, not the potassium, but the phosphorus. So to answer go back to my original question was, we would expect the BUN and creatinine to be elevated. ECG prolonged QT interval. So we're going to treat the underlying cause. We could either do peritoneal or hemodialysis. We're going to discontinue the drugs associated with hyperphosphatemia. Gastric lavage, if someone's taken a toxic ingestion of a lot of phosphorus. And then just, if they're hospitalized, we're just going to make sure that we put them on VTE precautions. So we're going to avoid all those foods that we talked about that were high in phosphorus: the chicken, the fish, the beef, the organ meats, the porks, the nuts, the peanut butter, dark colored sodas. All of those things we're going to tell the patient to stay away from. They can do activity as needed, but we're going to give them something called Phoslo, which will work on the GI system to help absorb the phosphorus that they don't need, and then they can poop it out. Okay. Give them IV hydration of normal saline. So the phosphate binders that somebody talked about earlier, but they brought it up under hypo when it's actually for hyper. That's why I didn't address it. So Sevelamer, which is Renagel, those are all your phosphate binders. Forsrenol, those will be your phosphate binders. Let me spell that real quick. That's one. And the other one was that's another one. And then you have, that's your other one. So the phosphate binders you need to give with food or after meals. You can also give aluminum salts, but we don't give those to patients that have kidney disease because that may now contribute to them having osteomalacia. We can also give loop diuretics. That was something someone brought up earlier, with normal saline replacements to enhance the urine excretion to get rid of phosphorus. but we're not going to give any phosphorus enemas. But we, as I said, we may prepare them for either hemo or peritoneal dialysis. And I believe that covers all of the imbalances, and we're not doing chloride. All right, I think the other piece that's a part of this section would be your renal failure. And I'll talk a little bit about that, but I'll do another Zoom session tomorrow in the morning for those who can attend. And then that'll cover that out because I'm getting a little pooped. In what way? In what way, Jessica? Are you talking about for the hyperphosphatemia? Is that what you're talking about? Yeah. That you can use peritoneal or hemodialysis. There's two different kinds. Peritoneal, it's really done through the peritoneal layer, and hemodialysis is done through the blood. And that one they go to, and I remember talking about this briefly, but they go to dialysis 3 days a week, and they have a 2-day off, but the doctor tries to get them down to what they call as a dry weight. So that would be more of their focus for both peritoneal and hemodialysis. But peritoneal, you can kind of travel with you. How do you know you're having a problem with your peritoneal, you know, the fluid that comes out? How do you know there's a problem? Okay, change in color, cloudy. So if it's cloudy, then, you know, that's going to, that should definitely be a key that, oh, there's some funk in there, because it should actually be clear. So, ooh, milky white. Ooh, that's gross. So what was actually in there? Did they, because I know it went to the lab, did they ever get the results back? Okay, so yes, they can have peritonitis, but what's the bacteria? Oh, I have no clue. Oh, that's okay. But yes, that's how you know that there's an infectious process that's in there. It's if it comes out cloudy and if it has an odor and all of that. So that is kind of a telltale sign of that. With hemodialysis, I mean, it goes through a machine. They're basically purifying the blood and putting it right back in there. And there's a lot of shifts that's going on between electrolytes, et cetera. And with that going down the way that it does, the patient has a lot of, you know, they go through a lot of changes. They go through, their body goes through a lot of shifting. And right after dialysis, they're usually really, really weak. They're not going to be a big ball of energy ready to hop around and all that. They're not going to be ready for any of that. So patients on hemodialysis, you know, they have a little bit more care. It takes them about 24 hours to recoup. So if they go home that day and probably the next day they start feeling a lot better, but then all in gearing up for going back the next day to do that whole process all over again. So it used to be really difficult to travel if you had to get peritoneal, or not peritoneal, but hemodialysis. However, not anymore, because if you set it up early enough, then you can actually go to a dialyzing center. Even if you're on a cruise, they actually dialyze folks on cruises now. So they're trying to make it a lot more transportable to help minimize depression and things like that for folks who have dialysis. But speaking about that, if you're having somebody that has what they call an arterial venous fistula, and I know I covered this prior, what is your nursing responsibility related to that? Okay, what's a thrill? And what's a bruit, Kristen? It's like, dang it. So you feel a thrill, exactly. So when you palpate the AV fistula, then it should literally purr like a kitten. And if you auscultate it with your stethoscope, it should feel, you should auscultate or hear turbulent blood flow. So you have to assess for that to make sure that it is operable. Can those things develop clots? Absolutely. They can get infected, they can develop clots. All of those are things that can happen. So, you know, just never walk away from the basics. Again, you're going to assess before you use it. Now, honestly, unless you are a dialysis nurse, you're not going to be doing anything with that AV fistula outside of what we just talked about. That's it. A nephrologist is not going to let you come within 10 feet of doing anything else to that AV fistula. Okay. So just, you know, don't try to be all extra and draw blood work and all that from it. I mean, even for myself as an ED nurse, I had to get special permission from the nephrologist, and he had to train me, and it was only 1 or 2 people in the emergency room that he would even let touch any nephrology patient. So he was praying against, you know, every god known to whoever, that one of the 2 of us was working that day. So just kind of, you know, it's a serious thing. Unfortunately, when they go to dialysis, people stick them in the same place in that shunt because it's a graft on the inside. They have to kind of create an extra vessel that can actually withstand the pressure that machine is emitting to flush the blood in and out of the body system. But if they stick it in the same place every single time, then all of a sudden they'll start getting ballooning of the graft. And so that's why you see those pseudocysts on their skin, on their, you know, where the shunt is. It just means they've been stuck too many times. And that's not appropriate. So let's kind of shut down for tonight. And then what I'll do for tomorrow, I'll spend about an hour covering a little bit more about the peritoneal and the hemodialysis, and then just go from there unless you have like a burning. That'll give you some time to soak in the stuff that we talked about today. Yes, it's venous access, Jessica. It's arterial and venous. So they have an arterial side and a venous side. It's 2 sides for that one. And they have different catheters. So they may have a Quinton cath, which is kind of temporary, and they can place it in different areas of the body. That one is a little bit different than an arterial venous shunt. The shunt is a permanent piece. So, you know, they have to go to surgery, have it placed, and then it takes a couple weeks or so before they can actually use it. They want to make sure swelling and all that stuff is gone away. So in the morning, let's look about 10 o'clock. We need you in our life. That's too funny. So yeah, let's look at 10 o'clock. So I'll go ahead and set it up, send it out to you guys. It'll give time for this to go ahead and download. And then it'll also give you time to kind of soak in what we talked about today. We'll kind of redesign what you've already done and just kind of put things in a silo. Don't have them crisscrossing all over the place. But you do know where to make the connections because we've already talked about it. All right, guys. We'll see you tomorrow. Good night.